If you're the meeting host, enter the host PIN followed by pound. If you're not the host, press pound.
Chrome version?
Yeah, I took the Chrome version completely down and came back up with Explorer. This looks right to me, but you got to tell me if you're seeing it correctly. This looks like it normally looks.
Okay.
They had appointments up until 3:15. So ours are from like 3:20.
This looks right for me. What are you getting?
I can hear you now.
Oh, yay!
And now I see TD looks better.
Okay.
I see you.
Okay.
How you doing, brother?
Okay, you're using Explorer from now on, okay?
I have that in my notes, but I remember we did it last time and it didn't work.
I don't know, but you're there. I see.
Okay, I've got the slides up. I've got the video. I think we're good. Finally.
You're going to hear me on video about 16 seconds after you hear me on the phone.
With exactly 10 minutes to spare.
Okay. I have that in my notes. You can probably hear yourself coming back.
Yep, I can hear it.
And that looks great. I see welcome to PETOS, and I see you in the bottom on the street. It'll show you on the side.
Okay. Yep, that's what I've got too.
That looks great.
Hey, make sure to sign in. Get your credit. Okay, do you see my presentation, my opening slide?
Okay, let me go back over. Okay, I still see welcome to PETOS because.
Yeah,
okay.
that is my opening slide. Yes, that's
like
it.
10:30 this morning. Sweet. 25 minutes ago.
Okay, I gotta start the recording. So,
I'm just delivering information. Oh, yeah.
Welcome, guys.
Hello, thanks.
No, thank you. We've actually got the technicals worked out now, I think.
It's hard. It's hard getting here every day. Or it's hard because of the workload. It's hard. The inbox just keeps going. Still good experience for a while. Love it and hate it at the same time. Strauss is really good. Really good paramedic. He loves it. I would like to never ever get back to once again. We're shaking, brother. That's good. But for now,
I'm gonna take a seat.
About pediatric emergency and trauma outreach series.
These have all been good. These are all very good.
Cool. Are you going to say on this? Or are you just going to introduce it? Say welcome.
They kind of just do their own thing. We house it. I might say something to you guys for a minute at a time. Other than that, I just stay out of their way. I need to finish some other PowerPoints. I might not sit through the whole thing or any at all.
How's everything else? Good kids, good life. Awesome. Things are great.
Yeah.
Yep. It's going to do their own thing.
Yeah, because yours are all freaking old.
Yeah.
Because you don't look that old to me.
I'm 43.
Yeah. You look way younger than that.
It's at least 42.
Yeah,
At least.
Are you in charge today? Or are you a paramedic guy?
I'm a paramedic guy, I'm a vaccine guy. I don't think they're in charge still.
Have you reviewed your file yet?
Oh, no. Heard you last time.
You probably don't need to. You won't be able to.
I can come up with 7 days.
Our review, yeah.
Like 90% pulse.
Yeah.
Let's go again.
Rocket? Is he retiring soon? What do you mean? Is he in trouble?
Why are you so rich?
He's very short. I've never even heard this.
Sounds really, really crap. Like, you're not going to you're not going to maintain your position.
Welcome to a Cisco meeting. You are entering the meeting now. This meeting is being recorded. You are the only participant.
Right, your contact info down in the right spot because I've lost it.
Okay.
I'll be right back.
I can try to pretend you. You're looking pretty grim. Rich clad, straight faced, and being sarcastic. You're not going to tell him we're sarcastic. It's my It's your gift. It's done. Now what's going on with I know where you are. All the time. That's true. I could just take her right up the canyon there. I've never driven one. I'll take you up on it. Okay. So, like city firefighters, I'm just going to take a second and talk to you. Thank you for coming here. This is the, I'm going to make sure I get the name right, Pediatric Emergency and Trauma Health Series. A whole bunch of videos online. We've already been using some of them for our training. They've all been very good. Hey, Chief. So, looking forward to this. Or else. More than this or else. It's a big deal to have you here for the speaker. We have great speakers, but as you can imagine, if they were speaking to an empty room, have a nice day with that, that would be really weird. So by being here, you guys are making it better. You're going to just get out of it what you put into it. It's a great opportunity to present questions to really an expert in our community and region. I'm going to pass this around. Just put your names on it, and I'll into your training and target solutions and the NREMT, okay? Questions? Sarah wouldn't let me take any more cups. What do I do with my Where's the?
a lot of chatty people.
Yeah.
But if they do send in a question, I'll raise my hand and ask it.
Okay.
Try to repeat the questions if you get them, just so that the webinar knows what they're talking about.
You got it.
We're gonna get started. All right, welcome guys. We are going to get PETOS started. Welcome, State of Utah. We're really excited that you join us on our PETOS webinar. We are thrilled with our presenter today. We have Dr. Katie Russell. She is a pediatric trauma surgeon, born in California, studied in LA, and also did a residency in Philadelphia. She has come to Utah to take over Primary Children's pediatric trauma group, so she's the head honcho. She's the big boss, and we're extremely excited to have her speaking to us today. Remember that you can ask questions live on chat, and we will be monitoring those throughout the presentation, and then at the very end there'll be a slide that will tell you how to get your certificates. Folks that are in the room, you're amazing. You make this presentation. Thank you so much. Just make sure you've signed the sign-in sheet, which I will pass around. Turn it over to Katie.
Thank you. There? Okay. All right, thank you guys for coming. So I think just to kind of go through my background, so yeah, I was a medical student in LA, so 4 years in med school. Then I was 6 years as a general surgeon here in Salt Lake, actually. So did trauma at Intermountain and at the U. And then I went out to Philadelphia and did 2 additional years. And then I came back pediatric trained. So I work at primaries. There's 10 of us. There's 10 trauma surgeons. So one of us is always there when you guys come into the trauma bay. And I'm also the head of our ECMO program at primaries. And today I would like to share with you guys some background and preventative measures on pediatric drowning. I have no disclosures, but certainly small group, feel free to interrupt at any time. And I left some time at the end too if you have other questions that I can answer from a surgical perspective. So this is from the CDC. So what is drowning? So drowning is any kind of respiratory impairment or respiratory compromise caused by either submersion or immersion in a liquid substance. Do you guys know what the difference is between submersion and immersion? It's actually the difference is not much, but it makes a big difference how they do medically. So the difference, if you're immersed, your airway is still above water. But if you're submersed, it's only like an inch difference. If you're completely submersed, there's no airway above the water. In the United States, there's an average of 3,536 fatal drownings every year. So if we're going to put that in other terms, 10 people across the United States die every single day of a drowning injury. And of those, 20% are kids less than 14 years of age. If you look at all pediatric patients up to 18, drowning is the second leading cause of death from injury after motor vehicle crash. So this is a major problem in our pediatric population, and that's why we wanted to bring it to PETOS today. So who is at risk? Males drown 80% of the time. So 80% of these drowning victims are male. In the younger age group, so less than 5, it's about equal, females and males, but after about 5, males drown more often. That age group between 1 and 4 is the most likely to drown, and minorities also drown more commonly than our white population. Other things that can put you at risk include the lack of ability to swim, lack of good barriers around lakes and pools, lack of supervision, the location. So Florida, for instance, has more drowning than some of the mountain states do. Lack of actual life jackets. So floaties are totally out. We need to be using quality life jackets on these kids. Alcohol in the adolescent population is a huge contributor to some of these accidents. And also seizure disorders put you at a higher risk. So that was our U.S. stats. Then the Department of Health also put out a Utah drowning pamphlet in 2015. And this quote's important. Water is dangerous at any depth. It takes just seconds for a child to drown. And I suspect some of you guys have seen that. I bet you've responded to, little tiny kids drowning in puddles, small creeks you don't think are going to be a big deal. Just a small amount of water can do it in these little kids. To go over our stats in Utah, 30 people die every single year, and we treat another 140 in our emergency departments or hospitals. And in that age group, 1 to 4, this is even more prevalent than motor vehicle crash. So this is the number one cause that kids die from an injury in that age group between 1 and 4. Here is a bar graph. So you can see here there's 365 kids over this, adults and kids over this 3-year period that were seen in our ER. These are people that were seen and they were kept in our ER for several hours and then let go. 58 people needed to be hospitalized, and sometimes those are really long hospitalizations, up to 6 weeks, 8 weeks if it's a bad drowning injury, and then 90 people died. To break it up into population age, again, here, this is the group that we're talking about. So you can see that a large percentage of people that die every single year are our pediatric patients. To break it up even more, you can see here. So here's 0, 1, 2, 3, and 4. So that's really the group that is at the highest risk nationally and here in the state of Utah. In Utah, the summer is primarily the time that this happens. So April to September, we see the most drownings in this state. Other states like California and Florida kind of see consistent drowning all year long. But certainly here we see the most in our summer months. Where do people drown? So the majority in Utah is open water. So 43%, this is rivers and lakes. Then 30% are in private or public pools. And then this one is surprising. 20% of these people are dying in the bathtub. Now that's some geriatric patients and some pediatric patients, but impressive that that many people are dying in small, like in-house bodies of water. The tub, so of infants, so in that 0 to 1 age group, 78% are dying in the house. And usually this is the little thing that they bathe the kids in, tips over in the bath, or buckets, or even toilets can be a place where these little tiny kids can drown. So it's really important not to leave water in any of those locations if possible. Toddlers are the pools. So we see this pretty commonly, that a toddler will come in after a pool drowning. And then the older kids and the adult population is usually an outdoor space like a lake or a river, often doing boating activities or paddle boarding is another one they've seen recently. So other activities like that in lakes. Alcohol and drugs is a big deal. So if you look at the adolescents, there's multiple papers that show that alcohol is involved in somewhere between 25 and 50% of those drownings. We all know alcohol influences balance, coordination, judgment, and it's heightened when it's sunny and it's hot outside, and it can contribute to these accidents. In one study, the relative risk of drowning was 31 times as high in people who had an alcohol level that was considered really high, compared to people who didn't have one that was high. Other factors in addition to alcohol and drugs are epilepsy. So this is often older kids that you no longer think need to be supervised in the bath, and maybe they're well controlled on their anti-epileptics, but it only takes one seizure in an unsupervised kid and they can drown in the tub. Autistic kids are also at higher risk. And then long QT syndrome. So there's a gene that affects people and gives them long QT syndrome, and sometimes drowning is the initial event that allows us to diagnose that disorder. So if a kid goes in cold water and they have this gene defect, it can set off the long QT, put them into an arrhythmia, and they can have a drowning episode, either a near drowning or a drowning. So that's really it for the background. Does anybody have any questions on that, or any discussion, experiences that people have had? All right. Anything out there to you? Okay. So moving on to pathophysiology. So what happens, right? So initially you go under, and the first thing that happens is that you hold your breath. And during that breath holding, a little bit of water usually gets in and it hits your larynx, which then can cause a laryngospasm. So that even makes you panic more. So you're already panicked, and then you have a laryngospasm. And with that laryngospasm, your CO2 goes up, your oxygen goes down, and you become acidotic, and eventually you go unconscious. We used to talk about something called dry drowning. We don't think that that's really a thing. But we know that about 10% of these people do have a cardiac arrhythmia, and that's usually cold water drowning. So the first event that makes you your heart stop can be a cardiac arrhythmia, but most commonly, about 90% of the time, it's a hypoxic arrest. So that's when after you are unconscious, then your glottis relaxes, and then you aspirate all that water into your lungs, and then you have hypoxia or anoxia. I just want to go through the different systems. So first talking about the cardiac system. So these arrhythmias, so a cold water induced arrhythmia or hypothermic arrhythmia will get better with oxygen. So that's not typically what causes somebody to die. Rarely there are instances of ventricular fibrillation, and we already talked about that long QT syndrome. Pulmonary, aspiration of a small amount of liquid, so 1 to 3 mLs per kilo, can cause a significant impact on gas exchange. So it increases the permeability in the lung. Things fill those little alveoli, the water or wherever you are, it fills that alveoli, and then you mess up the surfactant, and then all those alveoli collapse, and then you cannot perform any kind of gas exchange. Your pulmonary compliance is totally wrecked, and then you get this thing called VQ mismatch. You're not getting any air into your lungs, and clearly your lungs are not working well. After 12 hours, let's say you do get into the hospital, you can even have complications on top of that. You can get pneumonias, abscesses, especially if you inhale like plant debris or something. If you're in a lake, you can get abscess formation. There's mechanical injury from that water inside the lung, and then you can get acute respiratory distress syndrome. But the biggest point of this is it's not a pulmonary failure that causes these people to die. We're pretty good in the hospital. If you guys can get these guys to us, we'll be able to take care of their lungs. It's not that hard for us, but the brain is more difficult. So the central nervous system or cerebral hypoxia, this is the final common pathway for all drowning victims. So that's why we think about, warm water drowning, and we think about how long have they been in there, because we're really talking about how long has their brain been without oxygen. Any questions on that? Yeah.
They were surprised when you said that there's no dry drowning. A lot of people.
There is some. So the old teaching was that the larynx would have a laryngospasm, and it would be so tight that no water could get down into the lungs, and you could pull people out after hours and their lungs would still be normal because of the laryngospasm, and it was only a cardiac death. But I have not heard that that is actually true. Does that answer the question for who's ever out there? Okay. So let's talk about treatment. So it's really supportive care. This is trauma. It's what you guys do every single day. And CPR is really important. Immediate CPR. So children who have had CPR by a bystander have a good outcome 4.75 times more than people who did not have CPR. So really, that's what we can do. We can get their wet clothes off. We can establish an airway either by a bag valve mask or with an intubation, and we can do CPR on the way to the hospital. What do you guys think about a C-collar in a let's say a toddler drowning? Do you guys have protocols that say, are you supposed to put a C-collar on?
I think if it's suspected dive injury, suspected head impact, absolutely.
Absolutely, I absolutely agree with you. So I would say no C-spine immobilization unless there is a history of trauma, a witnessed diving accident, or you are pretty concerned that something bad happened to that kid before they went in, because toddlers specifically, and remember it's that 1 to 4 year old age group that most of these drownings are happening in kids, they're falling from their own height. It's really hard to break your C-spine when you are falling from this high. So I would totally agree. Only if you think there's trauma. Putting a C-collar on those little guys makes it way harder for you to intubate, makes it way harder to dry them off. And there's this one study that showed that only 11 out of over 2,000 people that had a drowning actually had a C-spine injury. None of them were toddlers, and all of them had like a witnessed diving event. So I think that was awesome. Yeah, I would say don't put a C-collar on unless you're pretty sure that there was some kind of trauma. Witnessed or suspected diving, and then the mean age of that's like adolescence. So the mean age is 14 and the people who have trauma like that. After you guys, I mean, once they get to the hospital, there's really not much that we do for them. It's really supportive care. So we can put bolts in. So a bolt in your head, it's like a little monitor that you just put through the skull, and it monitors the pressure in your brain, your ICP. It doesn't help treatment, but it can help with prognosis. You know, if ICPs are really high, we know that brain is really, really swollen, and they might be less likely to recover. We only get head CTs if we're worried that there was some kind of trauma. Seizures, we aggressively treat, and then we avoid fevers. There was a study, a big study that came out in pediatric patients where we looked at therapeutic hypothermia and found that there's no benefit. So at this point, we are just keeping these kids normal temperature. We don't want them to be hot, but we're also not making them cold. Steroids are no benefit. We really just try to keep them normal in the ICU setting. From there, I want to move on to cold water drowning, which I think is a little bit different, and we do have some unique things in the state to talk about in terms of cold water. I think you've had one other PETOS on this, so I apologize if I'm repeating, but I think it's a little different coming from the surgical perspective. So cold water drowning, you know, why is it important in Utah? I mean, pretty obvious, but our high snowpack and the spring runoff make us a setup for all patients, but especially pediatric patients, to drown right around the springtime. We also have these high altitude, really cold mountain lakes, and also people that are doing all kinds of winter outdoor recreation and can have, you know, avalanche or other cold water drowning kind of episodes. So this paper, this is kind of a landmark paper. So this came out in JAMA, which is one of the two most important medical journals, in 1988. This was an ER physician at Primaries and one of the cardiac surgeons. And it's one of the first papers that talks about using bypass in order to warm someone up and get them back after they've been submerged for a very long time. So this was a 2-year-old girl, and there was big spring runoff. It was in June, somewhere over in Cottonwood Heights. She fell into a little creek and then got pulled under and was stuck in a culvert under a road. And she was a very difficult extraction, and they think that she was underneath the water for 66 minutes. She got to the emergency department, at which point her core temperature was 19, which is real cold. So her core temperature was 19. She was not breathing. She was asystolic. She had fixed and dilated pupils, no signs of trauma. And then her pH was 7.25, normal's 4. So 7.25 in this circumstance is actually pretty good. Her PCO2 was 50, normal's 40, so a little high, but also pretty good. Her bicarb was 20, normal's 24, so pretty good. And then her potassium was 5, which is also in this circumstance really good. Normal's 4, but it's only just a little bit high. So here's a graph of what happened to this kid. So again, she's 2. We think she was under for 66 minutes. Then she got CPR for over 2 hours before we worked everything out. And that was partially in transport and then partially in the hospital, where we figured out how we were going to make this bypass thing happen, because it wasn't like set up, something that we do all the time. But she had over 2 hours of CPR. And then you can see, so this is when we put her on bypass. And then, you know, within minutes of going on, she got a normal spontaneous rhythm. So what this is, this bypass, we call it ECMO. So it's extracorporeal membrane oxygenation. And we basically, in all these kids, we cut down on their neck and we find the big artery and the big vein, and we put cannulas in those two structures. So we tie them off from the head. So like the carotid artery, we cut it in half, and then we put a cannula going down, and then the jugular vein also, we cut it off and we put a cannula going down. And that's okay in these little kids. They have all kinds of collaterals. But the idea is that we take all the blood out the vein, we put it in a machine where the blood gets really warm and gets oxygen, and then we put it back in the artery. So even if their hearts stop, we're basically warming them up and pumping their heart for them. And so based on this first report, we've now put that into our common practice at Primary Children's. So this was our initial protocol. So this is environmental hypothermia. They would come in and we would do a core temperature, so either a rectal or an esophageal or a bladder temperature. And if their temperature was less than 25, regardless if they had a pulse or not, we would put them on ECMO to warm them up. If they were 26, so in between 25 and 30, then we check a pulse. If there's no pulse, then we put them on ECMO. If they have a pulse in that and they're above 25, we'll just warm them up with other methods. So that was our initial protocol, and we looked at what we did. So we put 4 kids on ECMO during the first year that we had this really up and running, and we had 2 that survived, like walked out of the hospital, neurologic, 100% fine, and then we had 2 that died. We looked at it, after we'd done it for a longer period of time. We put 5 more kids on ECMO. Our results during our second paper weren't as good as the first. So you can see we put 5 more on. We had 7 that died, and we still only had 2 survivors. But still, 2 survivors that totally walked out of the hospital after being hypothermic and asystolic for over an hour. So still we have these great 2 survivors. Then we looked at everything. So the numbers are really small. It's only 9 kids that we're talking about, so nothing actually reaches statistical significance, but we were able to learn things about these kids to try to help us predict who's going to do better. So the survivors, they were getting CPR, or it was shorter from the event to cannulation. So it's about 120 minutes, the kids that survived, versus 150 minutes for the kids that didn't survive. So this is the range. You can see this line on the second one. So certainly there were ones that were shorter that didn't live, but we do know, the quicker that we can get them to us, the better. What about the cannulation time? So after they hit the door in the ER, how long until we had them on bypass? Less than 30 minutes for all, and even some of these guys in 15 minutes. So that's all pretty good, but clearly, if we can get them on quicker, they're probably going to do better. It's still, every minute counts in this circumstance. The temperature, so this is interesting. So if you look, the colder kids actually do better. So again, just going to that, cold is protective, and that's why we're doing this. So if there's a warm water drowning that's been had CPR for 2 hours, I'm not going to put them on ECMO. But if there is a cold water drowning, and I think that their brain's been protected, I don't care how many hours it is, I'm going to still put them on. Because we've seen people that after hours and hours and hours with quality CPR, like they have a meaningful recovery. So this kind of gets back to that submersion versus immersion. So, if someone's like their foot is stuck under a rock or something, but their airway is still above water, and they're getting cold, and then they actually pass out from hypothermia before they go under, that person's more protected. And I know none of us really know exactly what happens to these people usually, but that's what we think happens. We think they get cold first, and that's why their brain's protected. pH. So pH of the survivors was better. So, so regular pH is 7.4. So 6.7, 6.7 is real low. 6.6 is real low too. But you can see, we had 6.9s that did not get better. We also had 6.4s that did not get better. But clearly the higher the pH, probably the more likely they are to do okay. And then potassium, this is interesting. So potassium in our bodies typically lives inside the cells. Because there's some different ions that live outside the cells, but potassium is one that's primarily inside. So we think this is a marker of cell death, so brain death. So if the potassium is really high, that means you've busted up brain cells. So can potassium be a marker of, is somebody going to survive or not? So clearly the kids that survived had lower potassiums. They had near normal, 4 is normal. So normal potassium, are you more likely to survive? Again, none of this is statistically significant because our numbers aren't high enough, but something that we think about now before we put people on. The non-survivors had potassiums that were higher, up in the 6-7 range.
What determines which children have a high versus a low?
So we think that the high ones, that it's a marker of cell death. So a marker that they were actually hypoxic, they didn't have oxygen. And when you don't have oxygen, your cells blow up. So we think that the high potassium is a surrogate of the brain cells exploding because the brain is not good. So these are our 7 deaths. So clearly we're never going to do something heroic to make somebody an organ donor. We're always trying to save them. But, if there is a silver lining to some of the things we do, so 4 of these people who didn't survive, they did go on to be organ donors and save other kids that were in need of these organs. Something I'll talk about more. So there's something called decompressive laparotomy. So if they're so sick and so many of their cells have died and they require fluid, like tons of fluid resuscitation, sometimes they'll get an abdominal compartment syndrome where like their vena cava and their aorta and their guts are all being smushed because like the pressure in their abdomen is too high. And sometimes if we get into that situation, we'll do something called a decompressive laparotomy where we make a huge incision on their abdomen to let everything kind of breathe. So that happens in ECMO sometimes because these kids are really, really sick, but we know that's a really bad sign. So everyone that we had to do a decompressive laparotomy on died. One kid was able to donate, but those are the sickest of the sick. So again, from Primary Children's, we learned this potassium thing. We think higher potassiums mean cell death, mean the kids aren't going to do as well. We also found out that in our we've had 3 now, but in our survivors, they wake up quickly after they go on. So, they've been cold, they've gotten CPR, but as soon as we put them on ECMO and we warm them up, they are following commands at 6 hours after being on that. So they get better really quickly. Another thing we learned is that decompressive laparotomy is a very bad prognosis. And our results have also been substantiated by some other papers. All the papers so far are pretty low numbers, but there was this one review that was published in the New England Journal of Medicine, which is another one of the best medical journals that we can get published in. They found similar things. Sorry, my slides, I made them on a Mac. They got a little messed up, but potassium. So patients with a lower initial potassium have higher survival. So they found the same thing that we did. Again, it's because that potassium is a marker for cell death. The question is, what is too high? And we don't really know. We have had neurologically intact survivors, not at primaries, but at another institution with a K as high as 12. That's really high. So again, we don't know. Our Ks with survivors were about 4 or 5, but someone says that 12 has been okay. This review in the New England Journal of Medicine makes 10 a cutoff. So at 10, it's kind of questionable if people are going to be able to survive or not. To go back to the type of exposure, immersion versus submersion versus avalanche, immersion leading to hypothermia has the best outcomes. So examples, I gave that one getting kind of stuck under a rock. Another one is crevasse. I guess we don't have any crevasses in Utah, but certainly in other states we could get stuck in a crevasse and get hypothermic. That's another time that we have pretty good outcomes. Avalanche victims and then people who are initially fully submerged have hypoxic arrests, and those do not have good outcomes if we put them on ECMO. If an avalanche victim is pulseless in less than 35 minutes, they're probably hypoxic. So the avalanche victims that are longer, that had a longer time to get cold, are the ones that actually do better. Does that make sense? Like if there's snow in the face and there's no oxygen going to them, that's a hypoxic arrest before a hypothermic arrest. Other predictors. So even though we think pH, base deficit, and CO2 may correlate, they haven't in anyone's papers so far. Again, the New England Journal also said decompressive laparotomy is a bad sign. Minor trauma does not exclude them. So we're talking about a life or death situation. So, trauma is typically an exclusion for going on ECMO. But there's more and more instances where we're going to go on anyway. So just because they've had some minor trauma doesn't mean we won't put them on ECMO. And children who are going to do well respond relatively quickly. So we updated our protocol just slightly after our last paper that we wrote. This is important. This white box over here, so this is prior to Primary Children's. So what you can do is you can do CPR. You can establish some kind of an airway. You could attempt epi, and we said epi times 3. And then you can defib if it's a rhythm that you think that you can defibrillate. So those are the pre-hospital things that we recommend before getting to primaries. And then we've also put out a protocol, I don't know if it's hit you guys, that says if you have a kid who is hypothermic and they have no pulse, bypass any other hospital and come straight to us, because no one's going to be able to stabilize them. They need to go on ECMO, and they're dead at this point, and they need to go on ECMO. That's the only thing that we can do to save them. So really, those are the things that we can do for these hypothermic kids. The only thing that we change once they get to the hospital, we no longer differentiate the 20 and 30. If they're less than 30, they're hypothermic and they are candidate to go on. If there is no pulse, we activate ECMO, but if our potassium is greater than 9, we'll consider not offering ECMO based on our previous data. So we've updated, so we have 3 survivors, which is around 20%. So 20% of these kids are walking out of the hospital neurologically intact, and we're still enthusiastic about the program. Any questions on cold water drowning? Yeah.
That looked like they were limiting defibrillation to 3 attempts.
Yeah, that's a good question. It's not going to work. It might, but we think that the primary thing is hypothermia, and they really need to get on ECMO. So that's why we put 3 as a limit. We wouldn't fault you if you tried it again, depending on how far out you are. But that's the main idea with that, is we just think you need to move to the hospital. Let's get these guys on the machine. Yeah.
In the studies, did you guys find any correlation patients receiving ECMO the amount of time they were submerged before receiving quality CPR, and whether or not they survived?
That's a really good question. We did not. We did not look into that. I know the whole time, but I don't know the time of CPR. So the last thing really is prevention. And everybody knows there was some really high profile drownings last summer. So this is Bodie Miller and his daughter Emmy, and they have teamed up with 2 other families that had drownings last year. And there's been a huge push with the American Academy of Pediatrics to get people more knowledgeable about what we can do to prevent these kind of things. And this is a position paper that just came out. So the biggest things that we can do is make sure that pools are covered, make sure that pools have a 4-sided fence, and that they have constant supervision. In all of these accidents that happen, though, it was at a neighbor's pool. So, typically if you actually have a kid in a pool, you are really paranoid about, that possible situation. But it's, if you go over to someone else's house that has a pool, just kind of checking, like, make sure they have pool safety that's up to speed for a little toddler. It can really happen. All these families that have had drowning fatalities, they say, they literally were out of sight for like 3 minutes. And that can be enough in a warm water situation that they will die. Swim lessons used to be recommended at 4 years. We've decreased it to say now kids should get swim lessons starting at 1 year. Everyone should learn CPR, bystander CPR. We do think that is effective, even though I don't know from our study. There have been other studies that look at bystander CPR and think that people have better outcomes when they've had good CPR. And then life jackets that are of good quality is very important. They have a lot of educational material that can be posted, at pools or wherever on the AAP website. Again, this is the #1 cause of death after birth defects for these toddlers. And I can give you guys this website too. There's really nice documents on it. But stay within an arm's reach. Make sure there is a person who actually has to be watching these kids. And if you're going to pass it off, make sure you have clear communication. A fence around all pools, and then empty buckets, bathtubs, and those wading pools. Those little tiny blow-up pools that you can get at Walmart have been a cause of a significant number of drownings in that toddler population. And then, here's another pool safety document that they put out. So that's really all I have on drowning. Any other questions? Anybody have questions about anything? Trauma surgery related?
So they were asking us to repeat the question that we asked about the
Oh, I'm sorry. He asked me if I knew the time of bystander CPR before paramedics, EMTs arrived, and I do not know the bystander CPR on our studies from primary children's.
I guess the other thing, like I was interested in understanding would be, you looked at all the different aspects of the patients that you had.
Yeah.
I was wondering if you found any sort of correlation with the amount of time for the components and whether or not that correlation is relevant.
Yeah, he asked me if we know anything about the submersion time. And I have event to cannulation.
Yeah, you have the time for the patient that started and the time.
Yes.
I was just curious.
Yeah, we do not know that. Sometimes it's hard to get that information, because, it'll be like the 5-year-old kid was the other one that was at the scene. And the times are, I'm not sure that we necessarily believe them, but it would be interesting for sure. Yeah.
Back to the cervical dollars.
Yeah.
It's just 11 out of 2,200.
Yeah.
And there's been studies that they don't actually check the cervical spine. Why do they study that?
That is such a good question. And So the question is, so we're talking about sea collars. And, I talked about a study where in drowning victims, only 11 out of over 2,200 actually had a C-spine injury. And then one of our firefighters asked, okay, and then there's more and more data saying that sea collars aren't good, so why do we use them at all? And I think I'm not at liberty to really speak on that. My personal feeling is that we use them too often. But, I can't change all your guys' protocols like today, but I think that we are working. A lot of us realize that they may be more detrimental. We've gone away from backboards, I think, at least compared to 10 years ago. And, what is the future going to hold? I think that there's changes coming down the pipe. So I think that's a really great question, and more to come on that. Yeah. Anything else? Yeah. Uh-huh. So our ER protocols at this point are that if a kid comes in, we have to hold them for 6 hours. So we won't let a near drowner go home for at least 6 hours. I think that was in response to some of those events. I don't know any more information than that. Oh, I didn't repeat that question. The question was, there was some like SID events in the past, or, a near drowning episode that then has a cardiac arrest hours later. So yeah, my recommendation would be, if a kid has a near drowning event, you come to the ER. When they are in the ER, we will hold them for at least 6 hours to make sure that we think they're okay before sending them home.
Along with that, there is a lot of attention being given to kids that didn't drown, but spent the entire day in the pool swallowing and hidden in water. And he's like, I don't even know what they're calling them, but they're after the pool time drowning. Have you seen anything about
Dave, do you know about that? I don't. Does anybody else have any information on that? I don't have information on that. I'd be happy to look into it, though, and I'll give it to the next speaker.
Something we might talk about is the process of ECMO. A lot of our EMS
Yeah.
why they kick out of the room almost immediately when they arrive, how they go and maybe the logistics of that, what happens when they're moved out of the room.
Great question. So, do I need to repeat that one? Okay, so the question is, what's up with ECMO? Why do the EMS providers get kicked out of the room immediately when we go on ECMO? I would say, first of all, as the trauma medical director, I'm like on a mission to have more EMS involvement in our trauma bay. I would say the difference with ECMO is that it is a sterile procedure, and it is crazy every single time. So to go on ECMO, we have to bring an operating room team down. We have to bring a perfusionist, so there's this huge pump thing that somebody has to run. So a lot of people come down into a small space, and I think anxiety and stress levels are high, and that's why I suspect some of our surgeons may be dismissive and kick people out. Certainly, if I was there, I would be quite happy to have EMS personnel over in the other trauma bay on stools or something so that they could see the procedure. I think that would be a great opportunity. But the one thing is that it is a sterile procedure-ish. I mean, the kid is dying. There is some breaking of sterile technique compared to if we're actually in the operating room, but we try to be as sterile as possible. Yeah.
I just want to talk more about water temperature.
Yeah.
I responded on a 20-year-old cold water drowning not long ago.
Uh-huh.
With fairly significant submersion time. The rope swing into the water, whenever the water was never seen again. Until it back to the bottom. And we're the water rescue team, most of us on the back row here.
Cool.
So I was pretty interested in it. I asked our medical director for more information. He presented me with a couple of studies that made it sound like drowning is drowning. Forget about water temperature anymore.
Who's your medical director?
Dr.
Mm-hmm.
That it sounds like more than 15 minutes of hypoxia is a bad thing any way you slice it. And then even in your presentation, you presented that no therapeutic benefit to therapeutic hypothermias and those kind of things. I guess I really want to wrap my head around cold water versus warm water.
Yeah.
And more about maybe age populations and to what age that seems to make a difference.
Mm-hmm.
And kind of dive into that a little bit deeper.
Where was that rope swing?
The farming component.
And it was summer.
It was early spring.
Early spring. I mean, clearly we've had many saves, not only at primaries, but there's European studies. People who are cold and become hypothermic before they have a cardiac arrest, they can be saved. Now, we think it's 20%. So still, the majority of them are not going to live. But I'd have to look at those papers that Dr. Youngquist gave you. I would consider a 20-year-old a pediatric patient. I would if you brought that kid to primaries, we'd put him on if the temperature was less than 30 degrees. I don't know what the used protocols are. They're doing more and more ECMO. They just got a huge grant to do ECMO. One of the ER physicians did. So I don't know if their protocols will change.
What we found is that it's not so much the water temperature as the cold body temperature.
Mm-hmm.
We had a kid a couple of years ago, one of our survivors. The story was he was hanging out at the restaurant. And the story was that he had cardiac arrest, but he was wet when they got on scene, and his core body temperature was less than 25. So he put him on ECMO. He survived. The story, what really happened, was that he had been dunked in a vat of ice water over and over again because he peed his pants, and they were child but the story, there's no water in the story. There's no water in the chicken plant. But the core body temperature with the actual protocols.
Yeah. Sure. So we should transport anyone with cold body temperatures if we assume that hypoxia preceded cardiac arrest.
Hypothermia.
Not hypoxia.
So we're talking about a 20-year-old, and do we know what the core body temperature was? So we're just talking about different protocols at different hospitals and different medical directors, and someone said that any drowning is a drowning, and it doesn't matter if it's cold or warm. And so the story was a 20-year-old who was on a rope swing, went down and never came up. I mean, also with that, you can think, okay, there was probably trauma. Off a rope swing into water and never came up. But And so that would be hypoxia before hypothermia, most likely. But I think that Tia really made a good point that we don't know what the story is. Sometimes, so she brought up another case of a kid where there was no water ever in the story that was given to the EMS providers, but in retrospect, the child had been dunked in cold water, 20 times and it was hypothermic. So I think the point maybe to take out of all this conversation that we just had is you can even take drowning out of the situation. If there is a hypothermic patient in cardiac arrest at less than 30 degrees Celsius, we will consider putting them on ECMO, no matter what the story is, especially if their potassium is less than 9 or 10. Would they do that at Intermountain Medical Center, or would they do that at the University of Utah? I don't know their specific protocols, but I can tell you that we definitely would at Primary Children's.
Can you help relate that to what we can measure to then?
Yeah.
We have really crappy thermometers.
Yeah.
Touching people with our hands.
Yeah.
Determining how cold is cold. What perspective should we gain?
Oh, what equipment could you gain?
Well, I mean, obviously, probably it's very cold.
Yeah, because you just have the little stick-on ones, temperature, like one of these. Oh, tympanic. Yeah, I mean, those are not accurate for core. I mean, I would just assume, if you think they're cold, I would just assume they're cold and get them to the hospital as soon as you can. Esophageal probes are pretty easy to get in. I don't know that I would recommend that you all get esophageal probes, but I don't know. Dave, do you have any comments on that? Rectal and esophageal is the same probe, actually. Just depends which end you want to put it in. Yeah, so the question was, in EMS, usually our thermometers are not that good. It's usually the tympanic one or something like that. So how do we know if somebody's cold? I think you have a good idea. You can feel them and you think they're cold. I would just go as fast as you can. And if they're cold by the time they get to the hospital, then we'll kind of make that decision. Should you invest in esophageal probes? I have no idea about how expensive that is or what the training would be like or if it's worth it.
Online is asking for us to get microphones for our questions. This is great conversation. We want to be part of that.
We could probably do that. Anything else? Yeah.
How about salt water versus fresh water? Things like that. Was that any difference in the study?
They were all fresh. I guess, yeah, they were all fresh. Salt is typically better on the lungs because it's more physiologic. But again, it's not the lungs that kills them. It's really that hypoxia time to their brain.
Do you guys have any conflicts with the idea of coming straight to Primary Children's? Have you heard of different protocols and instructions?
No, we can do some more stuff.
Keeping that up for repeat patients regardless.
We appreciate you. Have you guys seen this MIST thing? So we tried to just, as part of a group of people, to try to help standardize EMS report and just give people a, I know that everybody's reinvented the wheel. IMED had one, Primary Children's had a different one. I don't know what the other hospitals in the Valley had, but the idea just if we standardize this and so you guys know what we're expecting and we know what you're going to say, no matter what hospital you go to, it might help improve our communication. So we've kind of been on a campaign to pass out these cards and try to get people to start using them. So I'd be interested if anybody had any feedback or anything we could do differently on that MIST situation. Right.
No,
yeah.
I think we're pretty set in our ways. This
Yeah.
is how we found them. This is what we did. This is what happened to them. Here you go.
Yeah.
I mean, that's what we do. Right?
It's pretty good. I mean, you'd be amazed with the variety of EMS reports that you get. You know, and maybe within your unit, you guys all practice and all have the same one, but they are all over the board. And I think that leads to some of that dismissive behavior by some of the people that receive in the trauma bay. You know, so that was the thought behind this. Try to get everybody on the same page. I know what you're going to tell me. You know what you're going to tell me, and we all kind of know the flow. Just to try to kind of act more like a team as we go through the traumas. And I thought it was really ridiculous that IMED would have a different one than the U. But if it's not working, I totally take that feedback also. Yeah.
Ryan here said he wasn't familiar with what this was. Could you briefly explain?
Yeah, absolutely. So this is not us in Salt Lake making it up, you know, so this was military first. And so it's mechanism of injury. So I'm trauma, right? So mechanism of injury, but also works for medical patients because it would be medical illness. And then injuries. So any injuries that you're convinced the patient has, or, you know, illnesses that the patient has. Signs. So that's abnormal vital signs, or symptoms that they are really complaining about. And then what treatments you've done before coming into the trauma bay. So it's what you're already doing, but just, you know, trying to standardize even the little guys out in wherever Wyoming that end up bringing us people. We're trying to give them the same format also so we can get everybody on the same playing field.
And all of the Intermountain and the Lead Mountain Star also have that committed into this. You're going to start seeing it across that.
Well, thank you guys for coming. I really appreciate it. And yeah, that's it. Thanks, Tia.
We really appreciate Dr. Russell and the time that she's given us. For those of you online, take a look at the instructions on receiving your certificates. I do want you to be aware we're going to have some exciting news next time. Because of feedback from the people in this room, Primary Children's has launched a universal EMS liaison line, and we're going to have that up for you next month. Then if you want follow-up on any of your patients, you're going to email that line, and they're going to get that information back to you. So that's exciting. Join us next time. Thanks so much, guys.
Yeah. Totally no.
Thank you.
If you're the meeting host, enter the host PIN followed by pound. If you're not the host, press pound.